Welcome, everyone. Just to mention that this is a hybrid session. We have people participating online. So let me start by welcoming you all to this session, panel discussion on the practical experiences and frameworks used in making case to include family planning in national health insurance package. My name is Omar. I work with Options Consultancy Services. I'm the regional lead for the Women Integrated Sexual Health Program. I'm based in Nairobi, Kenya. Options is a global health consultancy, and we work with change makers in government, civil society, private sector, and also health providers to ensure we have locally driven solutions to health system challenges in the countries. Under the WISH program, which is funded by the UK government, Options strengthen government stewardship of high quality, well-financed and accountable FP-SRH services. So what are we talking about in this session? So this session will look at opportunities, challenges, and experiences of including family planning within the health insurance benefit package of countries. And in this case, we are talking about national health insurance or social health insurances in the countries that we'll look at. I have with me a distinguished, and I dare say, youth-led panel. So working with the young people as part of the theme of this conference. So this panel, distinguished panel, will give us experiences from different countries. We have a centralized NHI model, which is Ghana, and we also have experiences from decentralized NHI model, which is in Nigeria. And of course, we'll also hear about, from a think tank, about how they have go around supporting countries to advocate for inclusion of FP into the benefit package using evidence to inform the decisions of development of benefit package in the respective country. So before we start, I know we've gone through 3 days now, depending on when you came, of conference. And I know that here we have a good level of expertise in health financing, service delivery, and FP, but allow me to just introduce two concepts that are basic to this panel. One is the concept of health insurance. And we know that in many countries, we have the drive to SDG 3.8, which is achieving universal health coverage. And most countries, especially in developing countries, low to medium income countries, they are moving more towards developing either a national health insurance or a social health insurance. And we know the other model for financing health, publicly financing health, is the tax-funded model that is in some countries like the UK. So in our example, we'll talk about the national health insurance or social health insurances experiences from Ghana and Nigeria. And we know that national health insurance, in as much as there could be funding by either the government, by the workers themselves, or the employers, or combination of both, or combination of the three sources of funding. And in most cases, looking at the countries that we are talking about, there is an element of government funding to support the marginalized or the underserved people to access health insurance, and we'll hear how that is working. But we also know that this national or social health insurance are designed to, the benefit package that has been designed provides either services at public facilities or private facilities, or both. So we'll hear experiences of how also family planning is provided at public and private facilities using the different country experiences that we have. So without further ado, I would like now to introduce my panel. First, I'll start with Ms. Essie Asare Pra. Essie is the Advocacy and Donor Relations Manager at MSI Reproductive Choices in Ghana. AC has a background in population and health and is currently works primarily with governments, CSO, donors, and private partners to remove barriers and shape or develop favorable policies and programs for the delivery of FPSRH in Ghana. Maybe raise your hand, AC, so they know who is AC. So this is AC. As I mentioned, youthful panel, you can see why. The second one, of course, again, Julia Kaufman is a policy analyst with the Center for Global Development. It's a think tank that aims to reduce poverty and improve lives through economic research and drive better policy decisions. Julia's work in CDG focuses on value for money in global health aid, sustainable family planning financing, health product procurement, and the use of data and evidence in development policy more broadly. And for Center for Global Development, they have written a very good book, and I think I'll encourage you to look at it. It's available on PDF online for free, and it's called What's In, What's Out, Designing a Benefit Package. And very good book for those involved in developing benefits package, designing benefit package, or reviewing benefit packages in the countries that you are working. The third panelist we have, Julia. I think you have known who is Julia. She can raise her hand. So the third panelist we have is Dr. Babatunde Segun. He's youthful, I must say, and he's on the extreme right. Dr. Tunde is the interim senior program officer for family planning at the Bill and Melinda Gates Foundation, Nigeria country office. Dr. Tunde is a public health physician with over 30 years of diverse and extensive experience in public health, particularly adolescent reproductive health and maternal and newborn health. Tunde executes the BMGF, Bill and Melinda Gates Foundation, FP strategy in Nigeria by conceiving, developing, and managing complex portfolio of grants and technical assistance at the federal level and the state levels in Nigeria. Prior to joining the foundation, Tunde held senior leadership position with Options Consultancy Services. We are proud of that. And Japaigo, and at the Federal Ministry of Health in Nigeria. So welcome, Dr. Tunde. Now, the fourth panelist is not here, Dr. Michael Oluoy. Unfortunately, he couldn't make it because of visa challenges, but I'll introduce him, and then we have a pre-recorded video that he will present during the session. So Dr. Michael is the Sustainability Lead and Health Financing Advisor for the WISH program in Nigeria. Dr. Michael is a health systems specialist, focusing mostly on policy and health financing in underdeveloped areas, including the north of Nigeria. He's based in Kano in Nigeria and serves or works in Kano and Jigawa State. As I mentioned earlier, he could not make it to be here with us, but I'm sure we'll hear his session through video link, which is already pre-recorded. So looking forward to a very interesting session. Again, welcoming the audience. For those who just came in, welcome to this panel discussion on designing benefit package that includes FP. So the session is that I'll be posing, the design of the session is that I'll be posing questions to the panelists, and I'll give them 5 minutes to answer. So there'll be 2 sets of questions. I'll do a first round, then I'll do a second round again of questions. Then we will go to questions and answer session from the audience that is here. Good. So starting with Essie, for 5 minutes. I know you and your colleague at MS Reproductive Choices have done a lot of work over several years to advocate for inclusion of family planning into the benefit packages or package in Ghana, NHIS. Why was this so important for you to include this? Welcome.
Right. Hi, I think my voice is quite audible without the mic, but for many of us that work in family planning programming, especially in contexts like sub-Saharan Africa that has socioeconomic several socioeconomic dynamics, and we know that cost is a barrier in accessing family planning services, and it's even higher for the most marginalized who have the highest unmet need for family planning. And so, I mean, the first things for us programmers, for us implementers, it's clear cost is a barrier. And if health insurance systems, as Ghana's health insurance is set to more or less advance equitable access, remove the financial burden for several categories of population. So the NHIA has several exempt categories. In the NHIA, that is the National Health Insurance Authority of Ghana, or the National Health Insurance Scheme, if I say NHIS. Exempt categories including the marginalized and the poorest. And so if cost is a barrier for these populations in accessing family planning services, then the answer is clear, including family planning or NHI is key to advancing access. The other angle is, as we're talking even this ICFP conference and the whole universal health coverage agenda, and as Ghana, at the time that this pilot, MSI and partners started this pilot, was working towards a UHC agenda, it was key that we ensure that family planning was prioritized. And one of the key mechanisms to ensuring access to all and also ensuring national ownership of family planning programming within the UHC agenda for us in Ghana was prioritizing family planning in the NHIS benefit package. And so it was important for us to prove to government that this was doable, to move beyond talking about including family planning on NHIS and actually doing it. Because when Ghana's NHIS was set originally, it was to include all primary health care, and there was talk about including family planning, and there was a legislative instrument that was yet to be adapted, and it had been so for years. And so it was important that as we were at that critical moment that Ghana was talking about the USC's agenda, certain USC roadmap towards 2030, the family planning was also prioritized in that regard. And then, of course, as around 2017, 2018, 2019, Ghana achieved it popular, if not so popular, middle income status with donor funds dwindling. We needed to start talking about local financing for reproductive health services, including family planning, that had traditionally been largely donor-driven. And one of the best mechanisms for us to ensuring that was using the National Health Insurance Scheme, because it's Ghana's most reliable health financing mechanism that is well established and can be used as a local financing mechanism to advance access to services. And so for us, these were some of the three key reasons that including family planning on our health insurance scheme was key.
Thank you very much, Essie, for that insight. I think now maybe to go to the next panelist, Julia. The question is, most of us in the countries that we're in or we are supporting, there's reforms, there's health financing reforms ongoing, and we are wondering what evidence do we have to ensure governments include family planning into their NHI or SHI reforms and benefit package. Julia, I think as a think tank, and I know CDG works in the area of looking at benefit packages and family planning. How can all members who are here go with a message that this is the framework that we will work on and look at when we are engaging governments and other stakeholders to ensure that family planning is included in the benefit package? Back to you.
Thank you. So I have 4 initial points on the why and some ideas for how of benefits package inclusion across countries. So first, as hinted at a bit, family planning services are often organized and delivered through vertical programs with dedicated funds that rely heavily on donors and NGOs, as well as out-of-pocket payments. And this off-budget vertical model can really intensify financing risks related to fragmentation, limited domestic resources, and as we've seen in the last couple years and before that, aid volatility. So in many places, at some point in their UHC journey, including family planning and benefits packages can really be a key move for sustainability, country ownership, and access. But I think there's an inclination in the family planning community to focus on all the ways family planning is unique from other health services, given the political vulnerability, the nuances of method choice, and those are all true and very real complexities. But when it comes to health financing, there are limited resources available. Of course, we push for more money for health, but in the end, there is a budget. And officials have to make decisions on how to spend those limited resources, and that involves weighing uses against each other. And ideally, they'll progress to do this based on the costs and benefits of those different uses. So my second point is this is actually a huge entry point for family planning advocates because existing evidence generated by many here at this conference, as well as a lot of US and UK specific work, suggests that contraception typically generates really significant cost savings for the health system, and thus allows policymakers to provide more health services in their package, not less, mainly by averting unintended pregnancies and associated maternal health costs that accompany those. So if we lean into comparing family planning services to other health programs, it likely looks really good. So next slide and my third point. I won't spend too much time on this because the country-specific examples you'll hear about are much more salient, but the main takeaway is that by using new and existing data, as my co-panelists have done, we can make the case that some initial package of contraceptive coverage has very modest cost or is likely cost saving. And this initial package could be what was previously financed by certain donors. Donors could still fund on budget into this as a combination of domestic and external resources, like what the Global Financing Facility is intended to do. And so based on existing usage patterns and the current available method mix, we can ideally assess the complete cost of sustaining contraceptive services through the benefits package. And then of course, all of the captured savings attained for the payer from the averted follow-on costs. And then from there, we can assess the budget impact of various service expansions to additional methods or new delivery channels. Though again, this modeling requires data on anticipated uptake changes with the expansions, the related averted unintended pregnancies and costs, and all of that. But zooming out big picture, the takeaway is that analysis on the benefits, costs, and trade-offs in ways that resonate with both family health financing and family planning groups is essential, and donors should be supporting this to inform their transition efforts, this sort of analysis. And my final fourth point on country context, next slide. So the use of this sort of analysis, the push for benefits package integration in general, really depends on specific country context and the maturity of a country's health insurance scheme. This is the opposite of a one-size-fits-all. So don't pay too much attention to what's in each of the cells here. This is really informal and illustrative and just meant to get ideas going. But the point is that package inclusion strategies and priorities have to be the right fit for a country's health system and financing status. So a country with high dependence on donors would likely benefit from donor involvement and financial support for contraceptive inclusion, helping move away from year-by-year volatility in budget line items. And these places are also a good fit for technical and financial support for priority setting and health technology assessment, which is, again, something the GFF seeks to do. And then in countries with less dependence on external aid, analysis on the cost effectiveness of greater choice or even more expensive access pathways would be a better fit. And one idea we've put forward at CGD is that donors could strategically target resources towards methods that are likely to become cost effective only after generating user demand, paying startup costs, implementing provider training, et cetera. and then transitioning those to countries once they are set up and provide better value for money as a sort of marginal aid approach. So I will stop there for now. Thank you.
Thank you very much, Julia. I'm sure now you have the framework of how you can include FP and SRH into the benefit package, either when designing or revising, depending on the opportunities that you have at the country level. So the next, I'm sure the question for most of us is, has this worked? So we have but two within a country of Nigeria. Nigeria in Africa is like a continent. It's a big country with 36 states, I think, and they say 37 governments, one country. So it's a very interesting decentralized system. So each state has a choice to develop its own benefit package and even state insurance scheme. So we are going to hear from two experiences, two different states in Nigeria, and we know the South, North, examples provide, a much broader, example for Nigeria. We'll start with the North, and we have Dr. Michael. He has a video. We'll just play the video after this. Dr. Michael worked with the Jigawa State Health Insurance Agency, which is a public insurance agency led by the government of the state of Jigawa, and he has examples, challenges, and of course successes of including FP in the benefit package of the Jigawa Insurance Agency. This, I think, insurance agency is fairly new. You will hear from him how long has it been there, and this, where he has reached so far. Can we have Michael's video? Thank you.
Why was it necessary for us to include family planning in the benefit package? This was very, very important to us as the WISH program in Nigeria, because we realized that the health insurance is a vehicle or an innovative mechanism for financing the demand side of family planning. So to eliminate the barriers to the demand side of family planning services, health insurance was important. So we invested resources and technical expertise in building the Jigawa Contributory Health Scheme. Secondly, it was important to prioritize the inclusion of family planning in the benefit package because we realized that the funding gap for family planning was huge, and the annual allocation for family planning services was small, and what we were able to get were small increments annually through a lot of advocacy efforts. So health insurance will help us to bridge this financing gap. Thirdly, we prioritize the inclusion of family planning in the benefit package in line with the Leaving No One Behind agenda, which is a global drive to attain universal health coverage. So as WISH program, we saw the need to ensure that both the poor and the rich, the healthy and the sick, the young and the elderly are included in a social protection mechanism called the Jigawa Contributory Health Scheme, so that no one is left behind. How do we convince the stakeholders? In convincing the stakeholders to prioritize the inclusion of family planning in the benefit package of the Jigawa Contributory Health Scheme, we adopted two key strategies. First was the use of evidence. So, as the WISH program, we developed an investment case to justify why it was important for family planning services to be included in the benefit package of the Jigawa Health Insurance Scheme. So, our argument was that family planning services are cost-saving. So, we did an analysis which shows the huge savings that will be made if family planning is included in the benefit package. So, we found out the amount of money that will be saved, because for every unintended pregnancy, that is averted through family planning services. There will be cost savings from the cost of antenatal care, the cost of delivery, if it is normal delivery or a cesarean section, the cost of postnatal care, and these costs will have been borne by the health insurance scheme. So we're able to convince the stakeholders and the decision makers in Jigawa State that by covering family planning services via the health insurance scheme, the scheme will be saved the cost of these health services, which could have been borne by the scheme. From our analysis, we also found that for every $1 that was spent on covering family planning services by the health insurance scheme, about $2.5 will be saved. Secondly, we use the demographic data to further show, to justify the need for inclusion of family planning in the benefit package. The demographic data of Jigawa at that time showed that with a total fertility rate of 8.5, the Jigawa population by projection will double by 2030. So from current 6 million, the population will become 12 million. And the implication of this is universal health coverage may never be achieved because the population will keep outstripping the available resources. And to make it worse, Jigawa is one of the poorest states in Nigeria with 87% poverty rate. So except and unless family planning was covered by the health insurance scheme and the barriers to accessing family planning services was removed through health insurance, it means that the population will keep growing and the poverty rate will keep increasing and universal coverage may never be attained because the resources will be outstripped by the growing population. In addition to this use of evidence, we also have to think and work politically because at the end of the day, the decision to include family planning services in the benefit package or not lies in the hands of the decision makers. So by thinking and working politically, we had to map the stakeholders in the room and we classify them into those who were blockers and the allies. So the blockers, of course, were the traditional institutions and the religious leaders. The traditional leaders and the religious leaders, who are the gatekeepers, had some biases against health insurance and family planning. So family planning was seen as a taboo topic, while health insurance was seen as a topic that was a bit sensitive because it is believed that God should insure everybody. So why do we need to worry about health insurance? So we had to reorient this set of people, set of stakeholders, by showing them the importance of family planning in averting maternal mortality. So we orient them by saying that family planning is the immunization or the antidote to maternal mortality, which was very high in Jigawa at the time. For our allies, we had the civil society organizations and we had to quickly build their own capacity on the imperatives of having a health insurance scheme. And working with the civil society organizations, we're able to convince the parliamentarians and the executive arm of government on the need and the urgency of developing the health insurance scheme and integrating family planning services in the benefit package. And these were some of the key ways in which we were able to think and work politically, in addition to using evidence.
Thank you, Michael. I'm sure he's virtually participating, although he can't join us because the system does not allow for live participation. 4 things from Michael. 1, economic evidence, the benefit, economic benefit. 2, the demographic story to really advocate. The 3rd, stakeholder analysis and designing specific messages for different stakeholders. In Jigawa, the religious, community, it's a conservative north of Nigeria, mostly Muslim. So targeted messages, framing the intervention around maternal mortality, which is very good. And the fourth, I think, talked about allies, isn't it? CSOs, like-minded partners who can work closely to advocate and make, result in the changes. So those four key areas are what has resulted in inclusion of family planning in the benefit package of a conservative, poor, northern Nigeria state. So we shift now to the south of Nigeria, more urban, I would say, metropolitan state, Lagos State, and I know that Dr. Tunde and the foundation have supported a lot of work. Have supported a lot of work in the state of Lagos to try and include family planning in the benefit package. And actually, the state of Lagos, I think, was one of the first states to start thinking and implementing family planning in the respective benefit package. So, Dr. Tunde, tell us about your experience and also the work of the foundation in supporting this. Thank you.
Thank you, Umar. Just like Michael, itemized, even in Lagos State, though it's a more cosmopolitan, very overpopulated, because everybody thinks if you want to make it, just go to Lagos, and the population is bursting as it seems. But even at that, there were challenges in introducing the full components of family planning into the health insurance scheme. If you know how Nigeria is organized, in the public sector, family planning is free. However, you only get free services for things like condoms, any barrier methods that doesn't need any kind of intervention. But by the time you need an implant, an IUD, anything that needs some form of intervention, then you are made to pay for what is called consumables, and so these are the things that negate, just like has been said by other speakers, cost is a challenge. And so there was initial resistance by some stakeholders, the state actors themselves, the insurance agency itself, because there's this fear that once you add family planning, the costs of premium will increase. And this is a state that is looking for people to access family planning services without having to pay for it. The government itself felt you keep overburdening the people if you then add the full components and they have to pay more. From the other side, the non-state actors, you have the private provider association groups who also perceived that, they will lose out. If government is pushing these things free to the public sector, and then you are now telling people to pay more, they will lose out ultimately. And then the beneficiary groups themselves, the women, apart from those who are empowered, who can then just go to a private facility to get whatever services, there was also that fear that if we are now being given the full components, the premium will go up and we will not be able to afford it. And that would then even negate the whole idea of having the health insurance if you have to pay so much money. And the other point was the supply chain related matters, because there's this issue of stock out, so how do you balance, if you tell people to pay more money, you expect to have the products there. So these were some of the challenges that Lagos State faced. And just before I stop, I'll tell you they had a 4-stage integration pathway. We supported one of our grantees, on an investment, what we call strategic purchasing for family planning. And they had this 4-stage integration pathway. They built consensus. The first thing was to build consensus. The Lagos State Health Management Agency, or LASHMA, is the agency responsible for health insurance. And so they had to sensitize them on the need for full components. One thing I didn't say was written into the then health insurance scheme for the whole country, the only thing that was free and family planning was just counseling. So you could be counseled, but if you then wanted a method, you had to pay, especially in the private sector. Public sector, like I told you, the barrier methods were free, so you could pick a condom without any issue. And so there was this consensus building and awareness, sensitization for the need. And the second thing was for them to be able to expand family planning services. So they had to identify facilities that were empaneled. That's the language they use. You have to empanel this facility, so that they had to expand the facilities that would be offering this wide range of family planning services. Then the third thing they did was to actually conduct an actuarial study, which then analyzed the data, collated the data, then they presented and validated the results. And that showed, in that actuarial study, it showed that if you then include the full components of family planning services, it would increase the premium by 425 naira. Now, if you understand the exchange rate, that comes to just about $1, and they did it based on a population of about 500,000 women, and the state government looked at it and realized that if we increase by just a minimal $1 with 500,000 women, if we increase the number of women that are enrolled, that cost actually goes down. And based on that, they decided they would not increase the premium for family planning, even though they had now included the full components beyond barrier methods, beyond counseling. So you could have injectables, you could have implants, and all these other services. And so what they then did was, the last thing was there to integrate family planning plus services, so they actually revised their family planning package. I mean, they revised the health insurance scheme to include these family planning packages, and then introduced other like TB, some HIV and malaria, so the family planning was like an inroad for them to be able to expand some of the other services and integrate it without an increase in the premium. So this is the Lagos State experience. Thanks.
Yeah, thank you very much, Dr. Tunde. I think if you have noticed is that Jigawa is mostly, the delivery system is mostly public facilities. Lagos, private sector, 70%, I think, somewhere I read. So how do, in public facilities, public system, maybe the government agencies easily can convince the government facilities to provide that services as part of the benefit package. But in Lagos now, you're talking about government insurance convincing private providers to put it in their services, and also in the benefit package. So very interesting. I think the other thing from Lagos is that free sometimes is not so free, isn't it? The only free in public facility was the barrier method. It was condoms, what do you call the barrier method? Private facility, high quality counseling as an FP, part of the benefit package. So you can see we are starting from a very low threshold, isn't it? So good that the response was very positive in Lagos. They did the actuarial studies, and at the end of the day, the worry from the providers was, will it affect the bottom line as a private provider? Because we saw that at the end of the day, they absorbed that. So good experience, private service provision in a cosmopolitan service, setting versus the rural setting, mostly through public sector. Now we'll go back to the panelists. We have worked, advocacy has been done. It's in the benefit package. The next agenda is system readiness, isn't it? Demand generation, making sure the health workers are trained, the supply system is ready, supply chain, service delivery system is ready. How can we really make sure that now the patients are able to go to the facilities, get access, get high quality access, and get full range of access. Now back to you, Essie. How did you do this in Ghana, knowing that NHIS is in the benefit package? How did you engage stakeholders, and what challenges are you experiencing currently after moving in that direction?
Thank you. I think Julia and Michael and Dr. Tunde alluded to the fact that bringing family planning on NHIA goes beyond even family planning program, and it's health financing and even national budget, budgetary allocation discussion. And within national budget, there are competing priorities like Julia mentioned, and you bring in different actors. So you have the National Health Insurance Authority, who are very much focused on health financing, not previously engaged in family planning programming, or may not even appreciate family planning because of their own perceptions, stigma. You have a National Health Service, who are implementers. They know family planning. They appreciate the need. You have other actors, donor partners. You have Parliament itself, because then you are trying to get an act in place. And you may have a parliamentarian that one may not even understand health financing, may or may not, or two may not even appreciate family planning, because family planning is also controversial. And like I think Michael mentioned, there are several perceptions and opposition already in place, and may not be willing to move in that regard. And so one of the first things trying to convince all these different actors was first and foremost to gain consensus, because without gaining that consensus, you can't proceed. And so one of the first things we did, even before the actuarial study or the pilot, was doing a pre-feasibility study. Was this possible? Understanding who could make or make this policy change that we wanted, and understanding the priorities of these different actors. The National Health Insurance Authority, what evidence could convince them? Because we have been talking about family planning on NHIS in Ghana for a while, and from that study, you understand that even though there was evidence elsewhere, Ghanaian government or Ghanaian policymakers want local evidence, show us that it can work here. And that's what even informed that a pilot is needed, a localized pilot is needed. And within the same actors, within even civil society, NGO, donor partners that are, of course, appreciative of the SRHR landscape, in that moment, there might be competing priorities and perceptions that maybe pursuing FP on NHIA at this point might affect another priority that a particular partner may be pursuing. And so doing that pre-feasibility study to understand where you either gain buy-in, or which people to take along or which people to drop behind and come back later to pull along that way. Do we wait for certain partners to accept that we need family planning on NHIS now and go with them together to government to gain that consensus? Or do we drop because of competing priorities, go to the highest decision-making authority, see if this is possible, proceed from there, get that buy-in, and then show them that we have gotten the approval to do this? And then, of course, there are several perceptions of, I think Dr. Tunde mentioned it, of what including family planning on NHI could mean. That those from either Ministry of Finance or NHI that would think that this could mean more cost to government. And so ensuring that all are on the same page, that we needed to do this to show that it's possible. First of all, it's a pilot. If it's not possible, then you know that you have the evidence to say you will not include it. Then once you see the evidence, then you can be convinced. And so once we've gained that consensus, we've developed the pilot together. It wasn't MSI Ghana pushing a pilot design on either NHI or Ghana Health Service. From the national level to even the district level, there was even validation of the pilot design. So there is that consensus. It is nationally owned. We are doing this together. And then the next level was putting in place a governance structure. Because in advocacy, even though this is a pilot, you ultimately want a policy change. And one of the things that you need to make sure is, in this process, what can we do to ensure that at the end of the pilot, the policy change is smooth? And so getting in place a governance structure that would, even within the pilot process, facilitate decisions and deliberations and ensure that the highest decision-making authority is well informed and aware of what's happening was key. And so we had a national steering committee that was at the national level with representation from the Ministry of Health. We had the executive director of the National Health Insurance Authority and her assistants and different director, about 3 directors from the NHIA. We had the Director General of the Ghana Health Service. Parliament, we had a Parliamentary Select Committee chair there of the time. They're part of that steering committee. You have even private sector, farm access, part of the steering committee. And then you have your civil society partners in there. And this was at that level so that they would give more or less the overall governance and direction to the pilot and more or less validate decisions that will be made in the pilot process. And then you have a technical working group. That is the core team designing the pilot process. And so once this governance structure was put in place, when at every point in time, when findings from the pilot is reported, they saw the cost savings that was made in the pilot process. We had about, in the 7 districts, we had 7 pilot districts and then pilot district and then 3 control districts. And in the 7 districts with about 7,500 FP services, we saw about 1.6 million direct cost savings to the National Health Insurance Authority. And they saw that. And then using the Impact 2 analysis, they saw the other demographic health impacts that Tunde and Michael have also spoken about. So it was easier for them because they had been involved in the process. It was easier for them to clear those first misconceptions that this might be extra cost and understand that this will be beneficial for the country. So even before the policy change was made, at the end of the pilot, government decided that in the pilot districts, we will not even stop the family planning or NHIs even before they announced their family plan was included on our national health insurance. And it was because of those structures that we had put in place. And that is how we were able to do it.
Thank you very much, Essie. So you've developed the package. It's included in the NHI benefit package or the package, the state level package. How do you implement it? So the Ghana experience is start small, do a pilot in few districts, use the evidence for scale up and to convince now the government that this is something we should take to scale. And the other key message from SE is that the pilot should be government-led. Very important. Government-led means the top leadership of government and not, sometimes we get it wrong and academician-led, and then it ends up, more as a research rather than really going into practice. So very important point from SE. Thank you. So Julia, back to you again. We have the benefit package. It's included. After 2 years, the government is again revising the benefit package. They are looking, the NCD advocates are coming in with a nice advocacy tool. We need NCD to be included. So, the benefit package is being revised. Someone is eyeing FP to remove it and put in NCD. So where do we come in and ensure that we convince the government that FP should remain? And everybody is talking about Best Buy. Can you tell us more about Best Buy? Thank you.
Sure. So this point is kind of cross-cutting underlying advocacy points in different places, but spending on contraceptive supplies from donors, governments, and out-of-pocket private spending makes up just around 1% of total health expenditure in low-income countries, at around 200 million. And in middle-income countries, the proportion of resources on contraception is even less. And now those are estimates for current provision levels, but if you estimate the cost of covering all future unmet needs across all LMICs, as Guttmacher has done, it's still under 1% of total health spending. So it's really a relatively modest sum compared to overall healthcare expenditure. And if you think about this in comparison to other health programs that receive substantial external aid, like HIV, TB, malaria, immunization, and those health programs are also thinking about transition into benefits packages with more domestic resources. The resource requirements for those asked of governments are just going to be much greater. And yet funders for those have been relatively proactive in engaging with countries on domestic co-financing requirements and other types of transition planning, which have kind of been derailed by COVID. But compared to those, contraception seems to be a much more feasible ask. So it's a best buy because it's relatively affordable even in nominal terms compared to these other health programs with really large resource requirements. And then going back to the research that's done through the pilot, the actuarial study, the pre-feasibility, it's likely to be cost saving for the health system. It's a win-win for everyone. And we can use new types of analysis, tools, and local data to make this case to non-family planning minded people in new ways that might resonate more with them. Thank you.
Thank you, Julia. So we have convinced, isn't it, the government that it should remain. So it remains. So we have implemented the benefit package, and I think what we've said so far, it's working very well. But sometimes things may not work out well, isn't it? So things do not work out as planned. So we want to hear now. We did this, we put it in the benefit package, we went for implementation, but one or two things didn't work as expected. So how did we go around and resolve that? So we'll hear from Michael, what did he experience and how did he go around resolving some of the implementation challenges?
We're able to achieve the integration of family planning services in the benefit package, but sometimes some of the beneficiaries of the health insurance scheme, they go to the facilities and there are no commodities. So service fails at the point of the service delivery point. So in some cases also, women go to the facilities and the facility does not have the preferred family planning commodities, and so these women are sometimes cajoled and coerced to take other family planning services. So the way we are trying to work around this is through advocacy for improving budgetary allocation for family planning services so that there will be no more commodity stock out at the facility level. So we are working, the team is working vigorously with our CSO partners to advocate for yearly increment in the budget allocation for family planning commodities and services. And then in addition to the funding, we are also working to see how the state can have ownership of the procurement process. So currently in Nigeria, what we have over the last couple of years is a situation where the federal government of Nigeria, in partnership with the UNFPA, procures commodities and distributes these commodities freely to the states. So the states receive the commodities. We're trying to change this narrative because the funding for family planning procurement at the federal level is drying up. So we're advocating that you need to keep increasing your budgetary allocation for family planning commodities. And when you get the funding, you need to procure your own commodities. So we're strengthening both the financing side, the supply side financing, which is budgetary allocation to be increased for family planning commodities, and the actual procurement process, the process of forecasting, quantification, the milestone distribution. So we are working with the state to see how we can strengthen this, because we know that this is very, very key for us to achieve commodity security for family planning services. Finally, I will be talking about the findings from an assessment conducted on the level of coverage for family planning services on the Jigawa Contributory Health Scheme. So, number one findings which we noticed was the low enrollment on the scheme. Well, this is understandably so, because we know that the scheme is still young, it's about 3 years old, but yet we feel it's still a finding that needs to be highlighted. Only about 4% of the population are enrolled so far on the scheme. The reason for this is mainly because more than 80% of the Jigawa population are in the informal sector. So Jigawa is an agrarian society, so a large chunk of the population, about more than 80%, are in the rural communities, are highly mobile population, and so they are hard to reach. They are hard to enroll. They do not have a predictable source of income, so it is difficult to enroll them and to make them contribute towards the scheme. So this was one key finding from our assessment. So we hope to, with support from our donors, to look at strategies for implementing a micro insurance scheme, which will be targeted at covering this large informal sector population in Jigawa State. Secondly, from our assessment, we found that although women are covered for family planning services, sometimes, or in most cases, they do not know the extent of their coverage. They do not know what they are covered for. Are they covered for short-acting contraceptive methods or the long-acting contraceptive methods, and to what extent? So sometimes women go to facilities and they are misguided by providers that they are not covered for this service or that service. So we look forward to increasing sensitization for women of reproductive age group in Jigawa State on what specific family planning and SRH services they are covered for. Because if they don't know what they are covered for, they don't know their rights, then they will easily be tossed around by providers who want to collect reimbursements without offering the services. Finally, we also noticed that we need to strengthen the data management system in Jigawa State. So poor data management system is another finding from our assessment. From our assessment, for example, we realized that because the health insurance scheme in Jigawa is manual driven, so the process of enrollment is manually done, the process of authorization is manually done, claims management is manually done. So what we find out is that access to critical data is a problem. So for example, if you want to know what family planning services are most women, most beneficiaries enjoying in the state, this data is not readily available. So the question of what are we purchasing cannot easily be answered because the data is not readily available. Then for whom are we purchasing? So what family planning services are we providing, and who are the greatest beneficiaries? Which age group are the greatest beneficiaries? So these are questions also cannot easily be answered. And so we hope as a program to strengthen data collection, data analysis, and data utilization for strategic purchasing in Jigawa State.
Good. Yeah, good. From Michael, what are the implementation challenges? Commodity security. You've put them on insurance, but enrollment is another thing. You know, it's not, the insurance does not come to the house. You have to go there, register yourself, get enrolled, low enrollment, lack of knowledge on the benefit package. You have to really communicate the benefit package clearly so that people know you're covered and they can comfortably go and access family planning services. And the fourth one is the ethical issue. You know, with insurance, the health providers have a motivation to actually provide the services. So if they don't have that family planning method, you know, there's an element of coercion in terms of to use a method that is available. So really, ethical issues, rights issues come in when you are implementing a family planning package where, you know, the provider, there's provider-induced, you know, the demand for a certain method, or to convince the provider to, to convince the client to switch a method without informed choice. Last but not least, Dr. Tunde. We've talked about this inclusion of FP in the benefit package, but how transformative is it as an agenda? And from the foundation perspective, really, where do you think this one is taking us to?
Okay, thank you. You know, we talk about more money for health, but we also should look at more health for the money we actually have or we get for health. You know, so from the foundation's perspective, all lives have equal values. That's our mantra. And if more and more women can access quality health services, you know, especially for services that have potentials to kill them, because in my country, pregnancy and childbirth, you know, in fact, there's a proverb in one of the local dialects that says that once you are pregnant, it's like you have one leg in the grave. You know, meaning that, you know, death is there staring at you at the face. But we all know that pregnancy is a physiological process and it doesn't kill. It's only when the women develop complications and there's no one to address those complications, especially bleeding, is when the problem starts. So for us, it's transformative in the sense that, and just like my colleague has said, for every $1 that is spent on family planning, you can save up to like $2.5, you know, where you'd have had to go through antenatal care, spend money on delivery. So for us, it's very transformative, meaning that there's removal of the barrier to access, and especially the financial barrier. So if I can pay a fixed amount per year and I can get this bouquet of services, I think it's transformative. And like Uma has said, you know, for a Lagos where about 70% of the population access health services in the private sector, the Lagos State Health Management Agency has empaneled a large amount of private sector or private facilities, you know, so it means that you can go to a highbrow private facility and get your family planning services free, you know, because of this insurance. Of course, the other thing is reduction in healthcare costs. Just as we've said, for every dollar, you know, spent, there are savings. And then the health benefits. So if, like Michael said, if family planning is the vaccine, you know, that prevents maternal mortality, the more women are on family planning methods, they can determine when they get pregnant, how many, how soon, and, you know, when they start or when they stop. It means that our maternal mortality and by extension, our neonatal mortality can reduce. So there's that health benefit. The fourth thing are the economic benefits. So we then can have a managed population, we can have an increase in a working population, you know, and less of this dependency. So if I can manage my family, for example, and I reach in public health parlance replacement level, you know, it means that I can manage those children, they can be productive to society, and then we can actually start talking about human capital development and the benefits of that. And of course, even like the motto of this conference, we can then be talking about attaining universal health care, or coverage rather, you know, because once services are in free, once you've paid your premium, you can have quality services, and these services can reach everybody in the population. And the last point is the predictable and sustainable financing. You know, just as has been alluded to, a lot of these things are donor-driven. So donor support investments to help governments. But once government takes it over, like the LASHMA, as of the last time I checked, they are averaging about 625,000 lives, as they call it, you know. So meaning that, you know, we're making progress. So once that kicks in, and by the way, LASHMA recently launched apps. So unlike Jigawa that is manual, they've gone digital. So you can register digitally, they have data that they can access digitally. In fact, on their website, there's a live count. So they have all those things. And you see, these things afford sustainability. So less and less of donor dependence. And that's the ultimate. If you can have predictable financing and sustainable financing, then it's a win-win for everybody. Thank you.
Thank you very much, Dr. Tunde. I think the key thing is, yes, it's transformative. Agenda, life-saving, demographic and economic benefit, and long-term possibility of sustainable financing. So we have, I think we are running short of time, but it's okay. I hope the panelists did a good job. But we have few minutes for few questions. I have seen any question. I have seen 1, 2, 3. Let me take the first. Okay, since Matthew is my friend, I can add him as in the fourth. So 4 people first. Then we can have a second round of questions. Welcome, Dr. Nadira.
Yeah, thank you very much, Omar. Definitely, thank you all the panelists. But I would like to go to the think tank, Julia. In fact, you know, you said that method mix is very important for health insurance or health coverage. You know, I'm coming from Bangladesh. This is Dr. Nadira Sultana. I was the sustainability lead and country lead for options when it was working there for the WISH project. And, you know, in Bangladesh, the family planning service is completely free, all the methods. But since last 12 years, we are stagnant in terms of the long-term and permanent method. The contraceptive rate is acceptance rate and the prevalence rate is 64%, but it's all for pills and condom, which are the highly, you know, financial transaction is required, even though government is giving all those are free, and there are incentive package for long-term and permanent method. But we cannot increase the rate, which is a target for AP 2020 was 75%. We cannot reach it. We are at the same position where we are in 2010. So when we are talking about the health financing and insurance for health coverage, the demand side need to be analyzed. What are the barriers? People are not getting services, though it is offering free. And you know, if we see all the method mix in a one package, it will not work. It should be method specific. Say for IUD or Norplan, there are longer term method. So the health insurance package need to be defined. Otherwise, you know, we can be misinterpreted the health insurance package. So thank you very much. This is the comment actually, not the questions. And same as the permanent method, we are encouraging, but we are not getting people's, you know, acceptance because these are the religious barriers. They said if something like IUD is in uterus, they will not, the Muslim ritual will not happen during when she died. Similarly, like ligation or tubal pregnancy.
Thank you.
Thank you very much.
Thank you very much, Dr. Nadira. I think who has the mic? The second question? Yes, please.
Great. Hi, I'm Stephanie Hyung. I'm with Chai Malawi. So I actually sit on the health financing side, not SRHR, supporting the government of Malawi to develop its benefits packages. So first of all, thanks for the really excellent presentations and moderation. I think there's been a lot during this conference that's been said about integration of SRHR and UHC, and frankly, this is exactly the way to do it, by designing and implementing benefits packages, so this is really excellent to see. So I have 2 questions. The first one is around how to look at the cost effectiveness of FP methods. I know we've talked a bit about averting not paying the cost of antenatal care and delivery, but I think, you know, modeling of FP effectiveness is incredibly complex. Like when you look at the population that like would not be there, you think about the loss, well, quote unquote loss, like economic productivity. There's all the conversation around demographic dividend. At the same time, that population that is not there is not using health services. So it's a bit of a butterfly effect. And so again, not to reduce people necessarily to their economic productivity. I'm not meaning to say that, but But how do you take that into account given the complexity of modeling FP compared to other kinds of health services? And the second question is how to reconcile this approach with, one thing I've been struggling with during this conference is how to reconcile this approach of health financing and health economics with what we're hearing about rights for FP. And during this conference, there's been a lot been said about FP's universal human right, but the health economics and health financing approach is a very different one. It says, if FP, if it is more cost effective, if the evidence shows it's a better buy than other services, then we include it. So to your question, for example, the moderator said about NCDs, hypothetically, I'm not saying this actually is true, but hypothetically, if NCDs were more cost effective or more equitable than FP, then it's hard for a government to justify including FP instead of NCDs, which again might not actually be true. But if it's immunization, if it's WASH, if it's malaria, if those things are better buys than FP, then you wouldn't include FP if you have limited resources. And so one thing I'm struggling with is how to reconcile that, very cold-hearted health economics.
Yeah.
I mean, we're in health economics, so we're the cold-hearted, dismal science. Like, how do you reconcile that with what we also hear during the conference about rights and, it's about, freeing women from the patriarchy, freeing women from saying they're only here to reproduce, which is also really compelling and moving. So I'd be curious how the panelists think about that.
Thank you. Third question, we can pick a third question. We'll do all the questions. I hope we can record them, then we answer once. Thank you. So we'll come to you.
Thank you to the panelists for the presentation. My name is Evelyn Boa from Kenya. I coordinate the MNH Coalition of Kenya that is supported by Evidence for Action Mamae to support grassroots organizations to use evidence to inform advocacy actions. Currently in our country, we are engaging on the CIDP, that is development of the budget 5-year plan to ensure that all things are budgeted for. And my question is, we have a number of challenges. Currently, we do not have a budget line on FP in our country. And we are seeing we have so much stockout challenges currently, and I don't know what can be done in that area. And then secondly, how can we increase accountability on health financing? Thank you.
Matt, yeah.
Thanks, Matt Boxall from Thinkwell, and thank you for an excellent discussion and great moderation as well. It's been fascinating. So I'm going to throw down a little bit of a challenge and maybe a slightly dissenting view. I see the panel smiling at me, maybe expecting that. So much to agree with. Government investment in family planning is a best buy. It is absolutely critical. Removing financial barriers to access is critical. Engagement with the private sector in some circumstances, Lagos is a great example, is critical. These are things we all agree with. Family planning must be central to any vision of UHC. That is a given. Where I disagree is the implication that UHC and national health insurance are the same thing. And we see in many countries, I saw a presentation yesterday from Indonesia, where JKN, the National Health Insurance Scheme, was completely conflated with UHC. They're the same thing. My colleague from Kenya will know there is a UHC scheme being rolled out under the NHIF. Mm-hmm. It's a health financing mechanism. It can contribute towards universal health coverage, but it's not the same thing. UHC is a goal. A health insurance scheme is a health financing mechanism. Where does family planning best fit? We need to look at the specific contexts in each country. Thank you for the matrix, very interesting. And we need to decide how best can governments invest in family planning. There are many questions around that, but the one question that leaps out to me is, we care about those women and girls who are most in need. That's where we need to target our investment. We agree. Is health insurance going to reach those women and those young girls most in need of family planning? Because if it is not, that is not the best place to invest scarce government resources. And when I hear from Chigawa, 5% population coverage, I talked yesterday to the colleagues from Lagos, similar coverage in Lagos, largely through civil servants, was what I was told yesterday. Those 5% of formal employees are not adolescent girls with poor education in remote rural settings who are most in need in family planning, and we will not reach them through health insurance. Ghana is a great example of one of the very few success stories in terms of coverage. I think Ghana is around 60% coverage through NHIF. Rwanda is up in the 90s. There are only 4 countries currently in Africa that cover more than 20% of their population through their national health insurance scheme. Every other country, more than 80% of people are not covered, and some of these schemes are old. NHIF is 50 years old now. So we have to look at who is going to benefit. We have to bring that rights-based approach, and we have to ask, yes, governments must invest in family planning, but that doesn't mean it has to be through national health insurance. There might be better ways. And my colleague from Bangladesh knows 65% MCPR. Nigeria and Ghana would dream of 65% MCPR, right? It's more than double. It's more than double. Did you use health insurance to achieve that? No. Government investment, community health workers, great community mobilization, all sorts of things, but not health insurance. So thank you, Omar. Sorry to go.
No problem.
I was going to ask a question, say, what is the population coverage of the health insurance schemes? But I think I've answered my own questions. So I'll be quiet. Thank you.
Thank you very much, Matt, for that comment. Maybe we'll go to the last question, then we can also respond to the comment from Matt.
Thank you. I'm Matthias Brucker from the Faith to Action Network. My question is about, goes to what was said from the colleague in Malawi, is that how rational, who are these decision makers and how rational are they? So that there's an assumption that they take rational decisions and that macroeconomic cost effectiveness arguments will be the best to convince them to integrate SRHI into insurances. But we think that sometimes these boards include religious actors. Some of them are medics, but others are clergy. And so they might not necessarily buy into cost effectiveness. And so we wanted to recommend to complement this great advocacy, it's needed, but let's complement it to include religious effectiveness. Can we make arguments that it's also effective from a religious point of view to integrate SRHI into that? And that would help, because in many boards, religious actors are actually also there taking decisions on what is included in the package. And in our advocacy, we want to take that route, partnering maybe with these cost-effective arguments. Yeah, thank you.
Thank you. I can see a colleague wants to add, maybe half a minute.
I just wanted some clarification from the presenter from Ghana about the advocacy that was done, just to find out, because civil society is very huge. It's very, was the faith there? Just that bit of the clarification. Were they involved?
Okay. Thank you. I know we are running out of time, but maybe 1 minute to each panelist to respond, mostly comments. Thank you.
Okay, let me just quickly respond. I agree with you that universal health coverage and NHIs are not the same. I did say in one of my benefits that it's just a way of attaining universal health coverage. In terms of reaching the most vulnerable, one of the things I didn't say is that in the Lagos state, they actually have what they call equity fund, which is 1% of their consolidated revenue fund that they dedicate to ensuring that those who are indigent and cannot pay, that the government pays for them. So they have that, and it's a huge amount of money, and in this year, they had done for 100,000 people. That may not sound a lot, but at least it's a starting point. Now, the other thing I would just say is that Bangladesh, Nigeria, different contexts, different issues. So we just believe that, health insurance is not the only way, but it is a way that we can achieve that. But the lady from Kenya, I think, it starts from giving the evidence and the justification to have a family planning budget line, because there's just no way you would, be able to provide family planning services without budgeting for it. So in my country, we have costed implementation plans at the state level. At the national level, you have budget lines for family planning, even though they are not really funding it. But now we've even stepped it down to the state so they can have their own state-funded procurement of family planning commodities. Each state is meant to have its costed implementation plans. So I think it starts from, if you have like a national, family planning blueprint, which will have, costing as part of it. But it's just impossible if you don't have a budget line to provide family planning. I think those are some I'll respond to.
Julia?
Great. So I'll recognize 4 challenges with evaluating contraception that get at some of the comments, but I'm not solving them. I'm just recognizing them all 4 together. So the first is the non-health benefits of contraception, and I have 2 microphones. The non-health benefits of contraception and figuring out how to do sort of cross-sectoral effectiveness analysis, thinking about the benefits for education, for the economy. And when you're dealing with a government, that gets complex. You're dealing with different ministries. If there are significant benefits for the education sector, should the Ministry of Education be funding contraception? Is that a case we want to make if we're talking about some sort of contraceptive inclusion decision that's not cost saving or cost effective alone for health? So the non-health benefits are really tricky. The second challenge is the counterfactual of excluding, we're not operating from an idealized blank slate of just developing an insurance scheme in a utopia. If we were to keep the status quo and not include contraception in a benefits package, there are some women who would discontinue or can't access and have unmet need, but there are some women who absolutely continue to access. So maybe that counterfactual difference between inclusion and not inclusion is very small. And in those places, we have to think about other ways to reach people. And that's something that we should own. And the other implication on method choice, so if you're adding in a new method, there are going to be, you have to consider that there will be new acceptors of that method who wouldn't have used contraception otherwise. There will be people who switch from method A to method B. So for modeling, that you have to weigh that. It's not a huge difference. And factoring in the method choice implications are really tricky and really important. And I don't think that there's a lot of great modeling or data there yet on the different uses and implications of those decisions. And I guess the last point I'll make is on the economics financing lens versus the rights-based lens. I think those are so intertwined and linked, because if we're not making explicit decisions about what to fund and what to cover, they're still being made implicitly and just without intentionality on how to maximize the health for the money. So I think this it sounds wonky, cost effectiveness data, but it really is at the core about maximizing human prosperity. That's what we're trying to do through these wonky actuarial ways. So I will stop there.
Thank you. Thank you, Julia.
Right, thank you. So also just to add, I think talking about cost effectiveness, and all of us are thinking that, like you said, most people are rational beings. When we were starting, our first focus was removing cost, piloting to remove cost, and that would advance access. But even when we started the pilot design, that changed, because we realized that we had to come back and redesign the pilot, because we realized that removing cost alone was not enough to advance access. Like you said, we had to add SBCC, and we had to add capacity building training, especially on LACS, because the Ghana Health Service, the national training system of Ghana is such that providers are not trained practically on LACS, and so then choice is limited by providers' capacity to deliver the access. So we had to include those two key components beyond removing cost to ensure that access is advanced. And yes, you are talking to different actors. We had on the steering committee, Christian Health Association of Ghana, because in our sector, religious bodies play a key role. So even at the And not just in terms of decision making and policy, but also Christian associations in Ghana are key in health sector. They have facilities, and most of those facilities provide family planning. So it was crucial that they were represented. And you have different actors with different priorities, like she mentioned.
Sorry, I think I have to just wrap up because the next team is almost busting
All
in.
right. So somebody is a hardcore health financer and someone cares about him. So we did different analysis to convince different actors, and you can't expect that just cost effectiveness will convince everyone. So doing that, your feasibility analysis to understand what it would take to get your policy change is key before just jumping into doing a pilot. That might just be a waste of your time. Thank you.
Good. Thank you very much, panelists. A round of applause for them. Two things, two parting shots from me. One, for the economist on the left side, a right does not have to be cheap. That's very important. You know, the right to vote is not cheap, but it's still done every 5 years. And I hope you'll not go to some of our African presidents and use the cheapness of, or not cheapness, but the cost effectiveness in terms of voting right. And the last one is Bangladesh. I think the issue of PPFP and menstrual regulation are things that unique to the family planning program. So those who are interested in knowing more about Bangladesh can talk to Dr. Nadira, but also read about it. Thank you very much, the team. Let's go to the next session.